My name is Ed Glaser. Give you a little on my background. I was originally an almost mechanical engineer. I was about 5 credits from getting my ME degree when I decided to go to podiatry school. And I was fascinated by this machine. And that's all it is. It's just a machine, the foot. And unfortunately, everything I was taught in podiatry school disagreed with everything I was taught in physics and engineering. And being a tinkerer, I went in my garage and tinkered and experimented for about 13 years. And in the process, unbeknownst to myself even, I had really taken a fresh look at biomechanics. And what I'm going to show you will disagree with everything you were taught about how the foot functions. And I'll show you why what we were all taught is wrong, and why Isaac Newton was right. Because really, it's nothing I did is that original. It's really Isaac Newton. I applied Newtonian physics to the foot. Let me start out by talking a little bit about what it is we're trying to accomplish with a foot orthotic. What are we trying to do? Putting this thing in somebody's shoe. And by the way, you're saying, why isn't he wearing foot orthotics? These are actually orthotic sandals. They have the orthotics built in. They're not available on the market yet. I always have an experiment, and in 110 degrees, I figured this was appropriate. Firstly, the first goal of foot biomechanics, interestingly enough, is to prepare the foot to hit the ground. One of the things I started researching very early on, I went to the Smithsonian Institute, and I started looking at bones. And I looked at the subtalar joint because the subtalar joint was emphasized in foot biomechanics so much. And I measured the angulation of all 3 facets when the calcaneus was held at a fixed angle, fixed inclination angle. And what was fascinating was the anterior facet of the subtalar joint, whenever it was level, the calcaneus was inverted. Inversion, if you remember, is part of supination. Supination is plantar flexion, inversion, internal rotation. Why do we heel strike with a supinated foot? That's because the anterior facet, when it's level, the momentum coming down the leg is running into a perpendicular. It's like running straight into the wall. Do an experiment. Get up some speed and run straight into the wall. You won't bounce left or right, you'll bounce back. So what I'm saying is, momentum coming down the leg hitting this perpendicular facet does not encourage you to pronate or supinate. And I'm going to show you that the subtalar joint actually turns out has very little to do with pronation and supination, which is totally against what you were taught. So why do we want to heel strike in supination? To prepare the foot for heel strike, to level the anterior facet so as not to encourage pronation. Because if you hit the ground in less supination, the anterior facet is tilted, the momentum comes down the leg, hits the tilted facet, and drives you into early, rapid, deep pronation. And that's where most of the problems occur. The second thing we want to do, the second goal of foot biomechanics, has to do with a problem that we see. Many people flatten the foot after they hit the ground. So the body weight is coming over an unlocked, collapsed arch. Why do we have a foot that pronates and resupinates with every step? Because as the foot pronates, the talus slides forward and internally rotates and drops. And that causes the talonavicular and calcaneocuboid joints, these 2 joints, to become independent. And therefore, the foot becomes loose, floppy. We need that to adjust to the shape of the terrain. We're designed to walk on earth, which is an irregular surface. So every time we take a step, we unlock the foot to adjust to the shape of the terrain. Otherwise, we'd sprain our ankle every time we took a step or hit a clump of grass. Then, as body weight comes over the foot resupinates. It actually comes up and resupinates. And the purpose is to make the foot rigid. Why do you want a rigid foot? And what makes it rigid? 2 things. Number 1 is all the bones nest into each other in a rigid structure, We call that in physical therapy, they call it the closed pack position, right? And secondly, when the talar head externally rotates, it lands on the anterior facet, which blocks sagittal plane motion between these two bones. When you block sagittal plane motion and you contract your gastroc, you have no choice but to rotate around the ankle joint and propel forward. So the reason we lock the foot is to facilitate propulsion, to allow us to propel. Now, if you come over an unlocked foot, you still propel forward. But we call it an apropulsive gait because we do it so inefficiently. It takes more energy to propel forward. So the talus slides back and externally rotates. What is trying to resupinate you? It's interesting. You've got two things that try to resupinate you. One is the stance phase leg in the front has the trunk behind it. As you come over the foot, you rotate or ratchet around the stance phase leg, trying to externally rotate the femur, externally rotate the tibia, and you're attempting to externally rotate the talus. But if the anterior facet is tilted, it's just too steep a hill to climb. It's not till you get into supination where the anterior facet levels, then that rotation can occur effortlessly. So the reason, our second goal in biomechanics is that we have adequate resupination by mid-stance. Mid-stance is when the body weight is right over the foot. You want adequate resupination to lock these two bones in the sagittal plane to facilitate propulsion. Does that make sense? So goal one was prepare the foot to hit the ground in adequate supination so you don't overpronate. Goal two was resupinate by mid-stance. Goal three is right out of Root's book. Root, Orien and Weed wrote the original text on foot biomechanics, normal and abnormal function of the foot, in 1977. And he said 60% of the force when you push off should be under the first metatarsal and hallux, under the medial side of the foot. And he was right. When they look at athletes that win the decathlon in the Olympics and have no injuries, that's how they push off, with 60% of their force under the first metatarsal. So the third goal is medial propulsion. Propel off the medial side of the foot. Fourth goal. The fourth goal is, wait, losing my mind here. Did you see a train go by? It was my train of thought. I'll think of it. Hold on. Let me get right into diagnoses. So I lose my mind. I'm so used to PowerPoint. We get like complacent because we don't have to think anymore. We have PowerPoint. It brings up the next slide. I want to start discussing a little bit about diagnoses, and I'll hit you with the fourth goal. It will hit me. The train will come right through again, come back into the station. First thing, interesting phenomena about the first metatarsal phalangeal joint. Did anyone bring one with them, a first metatarsal? Can I borrow somebody's first can I borrow your first metatarsal? Slip your shoe off. Put your foot out and say, ah. Interesting phenomena. If you push up on the first metatarsal head, the toe loses its range of motion in dorsiflexion. It becomes rigid. When you lower the first metatarsal, it moves. This is what's called functional hallux limitus. What happens when he stands? The first metatarsal goes up, it jams on its dorsal surface, and over a period of time, actually becomes, you get a ridge of bone sticking up on the top of the first metatarsal, and he has one, a great big ridge of bone here. That eventually becomes hallux limitus and hallux rigidus. And he was so young and alive. Hallux limitus is an interesting problem. You come over, there's two kinds of hallux limitus. There's structural and there's functional. Functional has to do with the first metatarsal elevating. So he jams it over and over again, and it won't move when he gets over at mid-stance. So he has two choices to get past this foot. He can go on point, or like a ballerina, but most people don't do that. Most people externally rotate the leg and roll off the inside of the big toe, creating a pinch callus on the inside of the big toe. And that's the most common area for diabetics to ulcerate. So diabetics ulcerate right there. Why do they do that? Because they're externally rotating. If you have hallux rigidus or hallux limitus and you're a runner, then you become a swimmer, because or you end up with rocker sole shoes. It's interesting. You ever seen the rocker sole shoes, the Skeechers? I love that because the rocker sole shoes have been tested and found to be enormously inefficient. So how do they spin that? They say it's the shoe for weight loss because it uses more energy to walk in those shoes. Interesting phenomena. We'll start talking about what happens when the foot collapses. The first metatarsal becomes free to move on its axis. Its axis is either straight up, depending on how the hallux tracks, or up and out to the side. As it goes up and out to the side, the adductor hallucis, which attaches to the medial side of the proximal phalanx, or the lateral side, pulls the hallux laterally, and you end up with hallux abducto-valgus. That's where all bunions come from. They don't come from ill-fitting shoes. They come from coming over an unlocked foot over and over again. When one joint locks, what happens to the joints proximal and distal to it? They become hypermobile, so your interphalangeal joint hyperextends, and you have a cocked up hallux. Then at the metcuneiform joint, you start jamming the joint on its dorsal surface, creating a bump on the top of the foot we call a saddle bone deformity. As the first metatarsal moves up and out, it stops bearing its share of the weight. Where does the weight go? It has to go somewhere. It goes to the lesser metatarsals. Underneath each of the metatarsal heads is a bursal sac. You get a bursitis under the ball of the foot we call metatarsalgia. Why don't we call it bursitis? Because I think we get paid by the syllable. So there's just not enough syllables in bursitis. So what happens is you end up with this metatarsalgia, and you have two little bones, if you remember, underneath the first metatarsal head, the sesamoids. What is the purpose of our sesamoid bones? We're taught to give mechanical advantage to the flexor hallucis longus and brevis. In actuality, they have a far more important purpose, and that is to reduce shearing force. If the skin stays stationary with the sesamoid while the metatarsal rolls over it, reducing shearing force on the skin. So when the first metatarsal takes a vacation, the lesser metatarsals don't have sesamoids, a shearing force occurs, and you either get a diffuse callus or individual corns or lesions under the ball of the foot. Now, underneath, going across the metatarsals, is a ligament, the transverse metatarsal ligament. As the foot flattens and the first and fifth metatarsals go out to the side, you end up strapping or tightening that ligament. When you tighten that ligament, more force ends up on the second and third interspace. Why? The first and fifth are going up. The second and third, interspaces get compressed, and the plantar intermetatarsal nerve gets squished. That's the medical term, squished. When it gets squished, the Schwann cell around the nerve enlarges to protect its nerve, creating the benign tumor we call Morton's neuroma. So we end up with Morton's neuromas. As you walk, you drag the neuroma forward, and it ends up in the space between the base of the phalanges, where it's intermittently squeezed, sending that sharp shooting electrical pain to your toes. So you get tired of dropping to your knees every once in a while because your feet hurt. You go to the doctor, and what does he do? If he's in a good mood or not, he squeezes right in there, and you remove one of his ceiling tiles, and that's a positive. So oftentimes what doctors do for that is they think that's caused by a congenital deficiency of cortisone between the toes. So they inject cortisone, and you hit that nerve, and you'll see air between the patient and the treatment table. And patient comes in for about 3 of those shots. By the 3rd shot, the patient's saying no mas, and you're saying that's fine. You've already had your minimum daily adult requirement of cortisone. It's time to trade. let's take your pain and give you numbness. And they go in surgically and remove the nerve. The trouble is, the nerve grows back. Axons grow back 1/4 of an inch every year, and it now grows under the newly scarred, thickened transverse ligament. Before it even gets to the toes, it's forming a stump neuroma. So neuromas have a very high recurrence rate. Meanwhile, these metatarsals start bearing too much weight. When the first isn't doing its job, the lesser metatarsals will stress fracture. And you see stress fractures in the second, third, and fourth metatarsals. Oftentimes, what doctors will do for those lesions on the bottom of the foot is raise a metatarsal. They'll tell the patient, I'm sorry, your metatarsal is depressed. We have to put little Prozacs between your toes. No, your metatarsal's depressed. We got to elevate it. So you had a lesion under the second. We elevated it. What happens? It goes to the third. You elevate it again. It goes to the fourth. This makes a lot of Mercedes payments, but doesn't actually help the patient. Fifth metatarsal. When the fifth goes up and out on its axis, you form a Taylor's bunion. As the foot flattens, it elongates. When it elongates, it pulls on the extensor tendons, the extensor hood, and you end up with hammer digits. Form follows function. What does that mean? It means if you walk around like this, if you function this way, you'll become this way. That's what it means. So if you walk around with your toes contracted, you end up with hammer toes. As the foot elongates, what does it do? It pulls on the plantar fascia. Several things happen. Firstly, you've got an axis of first ray elevation, right about here. The plantar fascia has a pull that's horizontal. I know it comes down at an angle, but the pull is transduced by the sesamoid. It's attached to the sesamoid, making it a horizontal pull. So you have a force and an axis and a distance to the axis. Force times perpendicular distance is torque, right? Little Newtonian physics. What happens when the arch drops? The distance decreases. To get the same amount of work out of the plantar fascia, what do you have to do? Increase the force dramatically. That increase in tension is what causes plantar fasciitis. Do you guys ever see any plantar fasciitis? Once or twice. I love to ask stupid questions. I was in Florida recently. I said, do you have any old people in Florida? They said, no, we have their parents. So as the foot flattens, you pull on the string on the bow and arrow, the plantar fascia, and you get the symptom we call plantar fascia. What is a symptom anyway? It's when microtrauma occurs faster than your ability to heal. That's Tom McPoyle's tissue stress theory. So you end up causing tissue stresses faster than you can heal. Now sometimes it pulls the periosteum away from the bone. The inner lining of the periosteum is osteoblasts that make bone. So you lay down Ocean, which absorbs calcium from the blood, and over a period of a few months, you start to see a shadow on the x-ray we call a heel spur. That has nothing to do with the pain. You can have massive heel spurs and no pain at all. You can have no heel spur on x-ray and horrific heel spur pain. The heel spur itself is a late artifact on x-ray due to the tearing of the periosteum. So don't worry about the heel spur itself. What you worry about is the ripping. Both heel spurs and plantar fasciitis are a process diagnosis. In the process of going from a high arch to a lower arch, you tear your plantar fascia, either away from the heel bone or in its length. So when someone has plantar fasciitis, they're screaming, help me, my arch is falling. What we did in the past was we gave them standard podiatric orthotics, and what did they do? They were relatively hard and flat, and they had posts on them that tilted the ground into inversion of 4 degrees. 4 degrees? Have you walked on the gravel recently? Every step you take is 4 degrees different, 10 degrees different. It's a ridiculous concept, and I'll get into why rear foot posting is absurd in a little while. So far I've mentioned, just to recoup, hallux limitus, hallux rigidus, hyperextension of the interphalangeal joint, saddle bone deformity, bunion deformity, metatarsalgia, Morton's neuroma, bursitis, individual lesions diffuse lesions, hammer toes, Taylor's bunions, plantar fasciitis, heel spurs. Also, as you pronate, the calcaneus everts, and the sharp lateral edge of the calcaneus, you notice the lateral edge is sharp, the medial edge is rounded. The sharp lateral edge gets behind the Achilles tendon, and the retrocalcaneal bursa starts to get inflamed. Retrocalcaneal bursitis. There's two little bumps on the bottom of the heel bone. They're called the tuberosities. The medical term is bumps. And when the heel everts, the medial bump bears too much weight, and the subcalcaneal bursa gets inflamed. That hurts at the end of the day, end of the run, because how does it inflame? By filling up with more fluid. It's a bag of fluid. As the tilts, the fibula jams against the lateral calcaneus, and the square peg, ankle mortise, tilts in the square hole. And it a pull on the synosmus fibula, and you get lateral pain. Interesting thing happens as the foot collapses. I happen to bring a knee with me today. Hello. When I hold my arch up, my knee is right on the sagittal plane. As my arch collapses, watch what happens to my knee. It internally rotates. The internal rotation of the knee, you'll notice, increases the Q angle, the angle between the vertical and the femur. Now the quadriceps, which attaches to the patella, and the patella is a free floating bone, begins to pull in a lateral direction. If you've ever looked at a femoral groove, you notice that the lateral side is very shallow, and the medial side is steep. So what happens when you pull laterally? You ride up the lateral side of the groove, come down and shear the medial. Ride up the lateral, shear the medial. And the infrapatellar cartilage, being only 5 cells thick, wears through. We used to call that chondromalacia patella. Now it's more correctly called patellofemoral tracking disorder. How important is that? 70% of all running injuries that stop people from running are that. The other thing that happens as the knee internally rotates is the ACL and PCL, which are parallel when the knee is on the sagittal plane, wrap around each other to the end of the range of motion. So what happens? You go to the end of the range of motion, plant, pronate, and twist, you rip your ACL. ACL tears are preventable. When you raise the longitudinal arch, put the knee back on the sagittal plane, you have 3 things you didn't have before. Number 1, you have time. Time to contract your musculature to protect the knee. Number 2, you have a resistive force resisting reaching the end of the range of motion. If you reach the end of the range of motion like this, you rip your ACL. If you reach it more gently, you don't rip your ACL. And thirdly, going full contact in the arch and raising it does what? It actually gives you proprioceptive knowledge of where your body is in space. So you're less likely to injure yourself because you would rather fall than rip your ACL. That's one of the most expensive injuries in sports. Why? I'm not talking about the $20,000 to repair it or the 6 months of therapy. What I'm talking about is it's the end of your season. It's the end of your scholarship, maybe the end of your career. ACL tears are expensive. I don't arrange my own lectures, actually she does. But I walked into this university recently, and I've been there, I'm having a deja vu, because I've been there 3 times. And I said, why do I keep coming back here? And they said, well, the 3 years before you got here, we had 15 ACL tears on the women's side. In the 3 years since you've been here, we've had 1. They said, you want to see the video? Somebody barreled into the side of her knee. No orthotic will prevent that. Okay. So what happens when the knee internally rotates? The fibers of the hip joint capsule, along with the iliopsoas muscle, cause an anterior pelvic tilt. The anterior pelvic tilt creates all kinds of problems. Firstly, it may not be symmetrical because you may not pronate symmetrically. So you may have, when the pelvis tilts anteriorly, it doesn't just go like that. It rotates and tilts simultaneously. So what occurs? Firstly, you wreak havoc with your SI joint. You get SI pain. SI strain causes a splintage of the paravertebrals. The paravertebrals become tight, causing the discs to desiccate, dry out. One day you're leaning forward to pick up the soap. You're not picking up the soap. You're picking up the top half of your body. In my case, it's the 150-pound soap. What happens? I open up the weakened back wall of the disc and push the nucleus pulposus right through it. You end up with disc bulging and herniation. On top of that, the discs, the intervertebral facets accelerate their arthritic changes. You get facet syndrome. The discs begin to narrow, squeezing nerve roots, creating numbness, tingling, and burning in the leg, we call radiculopathy. As you increase the Q angle, what happened? You tighten the lateral band syndrome, especially in women because they have wider hips and more Q angle in general, and more flexibility. On top of that, posteriorly, as you internally rotate, you're pulling out on the greater trochanteric fossa. So there are three muscles that come from the intertrochanteric fossa through the greater and lesser sciatic notch. They are the gemellus, the piriformis, and the obturator externus. So what occurs? You pull on the piriformis over and over again, creating piriformis syndrome. Then on top of that, what nerve goes over, under, or something through the piriformis? This largest nerve in your body, the sciatic nerve, pulling on the piriformis, tightens the muscle on the sciatic nerve, creating sciatica. As you increase your lordotic curvature, you increase kyphosis. I have no idea why, but you do. You probably can explain it to me. When you increase kyphosis, you're looking down at the ground unless you lift your head up. And you walk around with an anterior head carriage, which gives you headaches and neck pain. It also pulls on the platysmus and sternocleidomastoid, creating temporomandibular joint syndrome. What I'm saying is, the feet are the foundation of the body. And what happens to the feet over time? You have this tented structure, this arch structure that you're intermittently compressing between your body weight and this hard surface, the ground. What happens over time? The posture of your foot collapses. And that's why you develop all of these different diagnoses. So what were we taught in school? How many of you were taught neutral position? Put the foot in neutral position. Nobody ever heard of that? Everybody heard of that. What is neutral position? It's neither pronated nor supinated, they say. It's a farce. It's like saying, where's Chicago? It's neither New York nor Los Angeles. Where is it? The fact is, neutral position, if you look for where it came from, go into Root's book on page 124, you'll find, he says it came from an article written by Dr. Wright in 1962. Pull up the article, it's only 2 pages. Dr. Wright was an orthopedist who simply looked at 2 people standing, one of which was himself in the mirror. And he wrote this article. Well, that's not where neutral came from. In Lee's Clinics in Podiatry, Lee's article in Clinics in Podiatry, 150-page article, he interviewed Root before he died, and he asked him where neutral came from, and I quote, "In 1954, I was standing in the shower without any thought about the foot at all, when all of a sudden the concept of subtalar joint neutral flashed into my mind. That's what turned out to be the key to my being able to contribute to podiatry." I'm not saying you can't be brilliant in the shower. What I'm saying is there was no data. And there has never been a singular article ever that has validated neutral position as the correct position to put the foot in. And yet if you ask any podiatrist, they'll tell you, put the foot in neutral. In fact, when I was in school, the seniors taught the juniors in clinic. My senior pulled me aside one day and goes, "I'll teach you all of podiatric biomechanics in 1 sentence." I said, "What's that?" He said, "Cast them in neutral and make an orthotic." Interesting what neutral is. Let's look at what it is. It's a rotational position around the subtalar joint axis, correct? Firstly, where does the subtalar joint axis go? It exits here and enters here. Goes from dorsal anterior medial to plantar posterior lateral. And the rotation around the subtalar axis is a total of 6 degrees. That's all it moves. This is the motion all podiatric biomechanics is based on. Are you underwhelmed? Does that look like pronation to anybody? It's not. That's not pronation. What that is a locking mechanism. It's a window latch. When the two sides of the window get even, you can turn the latch and lock it in the sagittal plane against sagittal plane motion. That's all it is. My concept of biomechanics is based on posture. Let me explain the difference. Root's neutral position theory is based completely on a singular axis. When you look at one axis, you ignore all the other axes. There's not 2 bones in the foot, there's 26. You wouldn't have 26 bones and 35 joints if they all weren't being used in the gait cycle. So what is posture? The sum total of all of the motions around all of the axes of the foot simultaneously. Let me explain why the subtalar joint was quite possibly the very worst axis to choose of any axis, although it is the prettiest. It's the most interesting. It's 3-faceted, posterior, middle, anterior, right? It's askew, the axis to all 3 planes, so you get a triplane motion. It's interesting to talk about, but it has nothing to do with pronation, and I'll tell you why. The axis exits the foot plantar posterior lateral.